Good afternoon, everybody. I believe it's afternoon everywhere now. My name's Dr. Jim Galvin. I'm from the University of Miami Miller School of Medicine. And I'm gonna present the phase 2 results on CT1812 and mild to moderate dementia with Lewy bodies. And again, as Teresa mentioned, I presented this last week at the International Lewy Body Dementia Conference. So there's my disclosures. Many of you are familiar with this, but I think it's worthwhile just to put it into perspective. There's a lot of different symptoms that occur in dementia with Lewy bodies. It's really a multifactorial disease. There's lots of different symptoms. We have this little quote here. It's a buffet of symptoms. It's sort of fitting, though, because not all patients have all symptoms and not all symptoms are present at all times. So every time you go to a buffet table, there's something different there. And sometimes when you're dealing with a Lewy body patient, when you see them, there's something different there. But we broadly grouped it into, 4 buckets. So first is the behavior bucket, and in particular, symptoms such as hallucinations, delusions, anxiety. And we highlight these because actually these are symptoms that occur frequently in the patient. And when we developed the Lewy body dementia module for the National Institute on Aging Alzheimer's Disease Center program, we actually expanded questions to capture these domains. That's how important they are to both the patient and to the caregiver. And we have tools to be able to measure that, including the Neuropsychiatric Inventory, or NPI, as well as the care partner's distress related to these symptoms. Then we have the cognition bucket, and these are the different cognitive symptoms: memory, episodic memory, working memory, problem solving, etc. So we have a number of tools available to capture these concepts. One is the Cognitive Drug Research Battery, or the CDR. The other is tests like the Montreal Cognitive Assessment. And then we have the function bucket. And so these looking at the everyday activities of a patient. Not just basic ADLs like toileting and bathing, but instrumental ADLs like shopping, meal preparation, transportation, etc. And so we have the activity of daily living scale. And then we have a symptom that's cognitive fluctuations, which really impacts all domains. It didn't really have a bucket to fit in, so we kind of put it in this bucket. And so we capture that with the clinician assessment of fluctuation. And then the last, of course, is the movement disorder associated with DLB. This includes all the Parkinsonian features, and we can measure this with the MDS-UPDRS, Part 3 motor exam. So we have buckets of behaviors. We kind of define these behaviors, and we have instruments to measure these behaviors. And this is going to come back when I start talking about the outcome measures that we captured. So, of course, the SHIMMER study was designed to assess this multifactorial burden. This was a collaboration between all the sites, but also between Cognition Therapeutics, Academic Center, and the Lewy Body Dementia Association's Research Center of Excellence program. So, of course, you're familiar with the study design, so I'll just walk it quickly through. The key enrollment criteria: age 50 to 85, an MRI, a DLB diagnosis, and mini mental state 18 to 27 inclusive. It's a 1-to-1-to-1 randomization, so we have 1 dose of a placebo, and then we have 2 doses of the CT1812, either 100 milligrams or 300 milligrams. And so there were a number of assessments, and then we have the study objective. Remember, this is a phase 2A study, so the primary goal was to confirm safety and tolerability, and then to explore the impact of the medication across all of the different outcomes. And then one of the goals then would be to define a dose and outcomes that would help design the phase 3 study. So this is the baseline characteristics. So we have the 100 milligram dose, the 300 milligram dose, and the placebo. And you can see it's well balanced between the treatment and the placebo arms in terms of age, sex, race, ethnicity, mini mental, MoCA, CAF, UPDRS 3 scores, and the ADL. So nice balance. So that's great. That helps us understand the baseline characteristics. You can see that about 80% of the patients were skin biopsy positive for alpha-synuclein, or at least the phosphorylated alpha-synuclein form. You can see that about a third of patients were amyloid positive. This by plasma biomarkers, APS2. About 80% were on a cholinesterase inhibitor, and about a third of the patients were on some form of a dopaminergic agent, predominantly carbidopa-levodopa. Okay. So again, nicely balanced through all the groups in terms of their demographic characteristics, their underlying biomarker status, and their treatment profiles coming into the study. This is the consort chart. So we screened 293. We randomized 130, 44 to 100 milligrams, 44 to 300 milligrams, and 42 to placebo. You can see the completer analysis here that most people completed. The higher dropout group in the 300 milligram dose, 9 of them were due to AEs and 2 of them were due to withdrawals. So we'll come back and look at this, but this gives us an adequate population to do the intent to treat analysis as well as the safety profiles. All right, so this is the first slide I'm going to show you. I'm going to walk through the first slide, and a lot of the other slides will have the same general pattern. So first, just to set you up before I talk about what the data is, or over on the left side of the slide, I'm going to show you the typical kind of line graphs comparing the placebo to each of the 2 doses of CT1812, the 100 and 300 milligram dose. Then I'm going to show you the pooled data and compare that to the placebo. Okay. So on the first part of the slide, you can see what the p-values are. On the second part of the slide, then you'll see the pooled p-value. And then on the right side of the slide, I may show a forest plot or what domains are included in that scale, depending on what slide it is. Okay, so just to kind of set up how I'm going to show you most of the data for the trial. So let's look at the NPI first. So remember, the NPI catches a lot of different patient disturbances, but particularly including hallucinations, anxiety, and delusions. So if we look at the study, we can see that both doses, CT1812 100 and 300, were numerically superior to the placebo. And so we see p-values that are showing nice trends toward effect. Remember, this is a phase 2A. It's not powered for efficacy, and there's only 44 people in each arm, right? So what we want to see is that, is it moving in the direction that's favorable for treatment? And so we can see both doses look favorable. If we go to the pooled dose now, which you can see a blue line, you can see that, again, it's numerically favorable and statistically is very close to reaching significance. And so this relates in an 86% slowing in the NPI scores. And you can see from beginning to end of trial, there's very little behavioral change in the pooled group, where there is increasing behaviors in the placebo group. Now, if we move over to the right side of the thing, we can see a forest plot looking at each of the 12 components within the NPI. And you can see that anxiety, delusions, hallucinations all favor treatment with CT1812, as do most of the other domains numerically favoring treatment. So this very positive looking signal showing us an effect on behavior. How does that relate to the caregiver? Well, now let's look at that caregiver distress component of the NPI. Again, you can see that the individual doses, 100 and 300, are numerically superior to the placebo group. And you can see they almost are statistically significant. So again, we're really close to that statistical significance level, which is great for a phase 2A study, gives you a very robust signal to look at. If we go to the pooled data, now we have more people in the treatment arm, so this increases our power, and actually you reach statistical significance. So there's 114% slowing or lessening of the distress score in the treatment arms compared to the placebo arms. And in fact, if you look at the general pattern of the line, you can see that the caregiver distress actually at the end of the study is the same place it was at the beginning of the study, but there's a significant decline in the placebo group. And again, if we look at the forest plot, we can see that for anxiety, delusions, and hallucinations, again, strongly favor treatment with CT1812, as well as most of the other domains showing numerical advantages for treatment. Let's look at now some of the cognitive scores. So remember, this is the CDR, the Cognitive Drug Research. This is not the Clinical Dementia Rating Scale, okay? So if you've not seen this test before, it's a bunch of computerized tests that you can get some composite scores, but it does not have an overall global score, right? So what you can see is for the 5 composite scores that we can generate, something called quality of episodic secondary memory, quality of working memory, speed of memory, and power of attention. You can see that episodic and working memory, the individual composites both favors treatment with CT1812, as well as the composite of the composite, which is the quality of memory, also shows favorable outcomes toward treatment. And if we look at the individual types of tests, these are the subtests within the CDR that generate the composite scores. They tend to favor treatment with CT1812, specifically around episodic memory and working memory kind of tasks. So now I'll show you the more traditional kind of lines. Here we can see for the CDR quality of episodic memory, for the quality of working memory, and then for the quality of memory, which is basically a composite of these 2 prior composites. You can see for episodic memory, you get a nice numerical benefit for treatment with either the 100 or 300 compared to the placebo. Working memory is a little bit noisier, but you see something that suggests a numerical advantage. And then for the quality of memory, again, a little bit of noise in the middle of the trial, but at the end of the trial, you can see it suggests treatment has benefits. If we move to the pooled data, again, you can see numerical benefits for the episodic memory, working memory, and quality of memory tasks. And again, p-values that show pretty good trends toward the treatment, favoring treatment. Now, one of the challenging parts of dealing with DLB patients, as you all know, are the fluctuations. And so these things are intermittent. They're not always present, but if they're occurring during a presentation, during a performance, it could affect performance, it could affect their everyday functioning. And we can measure this with the CAF, the Clinician's Assessment of Fluctuations. So again, at the end of the trial, you can see that both the 100 and 300 milligram doses are numerically superior to the placebo group. And you can see by the end of the trial, they're actually staying right at the same level they were at baseline, so there's no increase in fluctuations. So if we look at the pooled data, we can see a 91% slowing in cognitive fluctuations in the treatment arm compared to the placebo arm. And again, we see an improvement in the p-values with the higher population of pooled data, again, suggesting that we have numerical differences that show interesting trends that help us as we design the phase 3 studies. What about activities of daily living? So again, you can see both, 100 and 300 milligram arms are numerically favoring a treatment compared to placebo. And if we look at the pooled data, we can see as 52% slowing between the pooled arms compared to the placebo. And again, we're approaching statistical significance with the higher power we get from the higher sample size of pooled data. What about on motor function? So this is the UPDRS part 3. And again, you can see some numerical advantages between the 1 and 300 milligram arms compared to the placebo. And if we look at the pooled data, there's a 62% slowing of the Parkinsonian features by the UPDRS. And again, you see that some interesting trends there as well. So what about the other outcomes? Well, you can see here for the MoCA and for the Epworth Sleepiness Scale, there's minimal changes. It's kind of noisy data. It's a little bit hard to sort it out. The 100 has a little bit of a numerical advantage compared to both the placebo and the 300 milligram dose for the MoCA. And you can see the Epworth Sleepiness Scale, there's some very big error bars there. So there's a wide range of responses on the ESS. So now you think about the treatment of Lewy body dementia, that's and anybody who's taking care of these patients, it's a real challenge when we think about that buffet of symptoms. You treat the cognition, you can worsen behavior in motor. You treat motor, you can worsen behavior in cognition. You treat sleep, and you can have effect on other symptoms. So it's a constant battle dealing with this. As you're treating one symptom, you often worsen other symptoms. But pretty much here, I've showed you across all of the different outcome measures, there's a favorable profile for CT1812. So if I show it to you, this is the pooled data, by the way. If I show you this all in sort of one forest plot, you can see that there is a number of profiles that favor treatment with CT1812. So we can see this in NPI total score, in the distress score, in the CAF, in the quality of memory, in the UPDRS, even in the MoCA with this really wide, noisy error bar, the ADL scale, as well as the CIGIC. So across the board, this numerically favors CT1812, with a number of these scales already sort of reaching statistical significance in this small phase 2A study. What about biomarkers? Well, what we've seen so far, there are no significant treatment differences. We looked at the change from baseline levels in plasma using known biomarkers of neuroinflammation and disease biology. We also are in the process of looking at change in baseline in the phosphorylated alpha-synuclein 129 via the skin biopsy. We saw a trend toward a reduction in NFL, but no other changes in the plasma biomarkers, and additional exploratory proteomics are thought to be performed. So you can see all the biomarkers that are being looked at. Some of these are with C2N, the monomers, some of them with other labs, and then measuring some exploratory plasma biomarkers through other companies as well. All right, let's look at the safety data now. So again, I'm going to show you 3 slides with the safety data. The first is looking at sort of the percent of people who have treatment emergent adverse events, SAEs, AEs, etc. Look at the 100 and 300 milligram arm versus the placebo, and then we'll look also at the total. In terms of having one treatment emergent adverse event, you can see that it happens across all the groups about equally. Related to treatment, there's a slightly higher number of effects in the 300 milligram group. AEs leading to death were exclusively in the treatment 300 milligram group. There was none seen in the 100 milligram group. And you look at the severity, mild was seen more in the 100 milligram group, and the moderate and severes were seen more in the 300 milligram group than we saw also in the placebo group. If we look at the most common treatment emergent adverse events to occur, we have falls, a headache, a lipase increase. And so you can see that there's a little bit more in the 300 milligram group compared to the 100 milligram group. This also includes changes in liver enzymes, where it seems to be mostly in the 300 milligram group, although there's a little bit seen in the 100 milligram group. And so if we kind of look at this across the board and sort of summarize it, the total AE frequency was similar in CT1812 compared to placebo. Most of the AEs were mild or moderate. There were fewer serious AEs in the treatment group compared to the placebo group. There were no deaths related to study drug. Study discontinuations were not related to elevated liver enzymes. But for participants who had liver enzymes greater than 3 times the upper limit of normal, it was 6 in the 300 milligram group and 3 in the 100 milligram group. And the most common AEs, other than increased LFTs, were diarrhea and abdominal discomfort. So again, if you sort of look across the board here in sort of summary kind of table, you can see adverse events between treatment and placebo groups are similar. AEs are actually, serious AEs are not seen in the treatment group, and deaths are 2 to 1. And most of these were in the 300 milligram arm. So walking through the treatment data, the safety data, and sort of the profiles of what we've seen in the different buckets that we discussed in the beginning, there's strong early data supporting the continued investigation of CT1812 as a treatment for DLB. The SHIMMER study suggests that CT1812 can slow the progression of symptoms in DLB. This is evidence across multiple endpoints: behavior, cognition, function, and movement. And so we believe that these results support advancement of CT1812 into late-stage trials. Again, as we think about, want to acknowledge all of the study partners, study participants and their study partners, of course, all of our sites and their personnel for doing an amazing job. This is not an easy disease to study. And I think as a group, we came together and we got this trial done. It was a little slow getting started, not surprisingly, coming out of a global pandemic. But I mean, everybody really kicked it into high drive, and we got everybody recruited. Matter of fact, we over-recruited by a couple of people, and I think that everybody should be commended for a really excellent job. Of course, to our collaborators at Lewy Body Dementia Association, this was funded by a grant from the NIH, and of course, the colleagues at Cognition Therapeutics and our CRO partners. I'm not going to thank myself, obviously. So I think this ends sort of the presentation. So if there are questions, I'm happy to take any, but thanks for your attention.